So, students, today we will discuss a very important topic in rectum, rectal carcinoma. Okay. So, as you know, what is the commonest carcinoma in rectum? As you know, rectum is lined by columnar epithelium. So, 95% of the carcinoma here is adenocarcinoma. Okay. So, adenocarcinoma of the rectum is nearly 95% of all the cancer is adenocarcinoma. Rest are GIST, gastrointestinal stromal tumor, carcinoid, and lymphoma, and other very rare malignancies. You have to remember adenocarcinoma is the commonest. Next comes lymphoma, then comes GIST and carcinoid. Okay. So, what are the risk factors for getting carcinoma of rectum? You see, 80% or 75 to 80% of rectal carcinoma is sporadic in nature. That is, they are not associated with any risk factor. They occur without any rhyme and reason, and nobody knows who will get it. Okay. But there are many risk factors associated with carcinoma of the rectum as well. What are the important risk factors? One important risk factor is, let's talk about the patient as a whole. As you know, most of the malignancies age. Okay, above 50 years of age is associated with increased risk of rectal carcinoma. Male, female is almost a bit equal, but a little bit more in male as compared to female. Okay, dietary habits. Well, increase of red meat, high saturated fat, low fiber content is associated with increased risk of rectal carcinoma. And so is alcohol consumption and smoking and tobacco. They are also associated with increased risk of rectal carcinoma. Small risk is there after cholecystectomy also, because bile is there and bacterial growth can occur. And that it has been shown that after cholecystectomy there is a bit increased incidence of colorectal carcinoma. Well, then you have obesity is a risk factor for rectal cancer, as it is in many other cancers as well. And then we have got genetic factors. These are important factors. Certain mutation in the genes occur which can lead to abnormal proliferation of cells, adenoma, and then carcinoma. A well known is APC gene, adenomatous polyposis coli gene, which is located on chromosome 5. Okay, this gene, there is some mutation occurs in this gene which leads to excessive formation of beta catenin, which is responsible for transcription of various proto-oncogenes which control the cell growth and replication. And excess of this will lead to tumor formation. Okay, so APC gene mutation as in seen in condition called familial adenomatous polyposis coli. Okay, I will tell you about this. Other genes or mutations of which are responsible for colorectal carcinoma are P53 oncogene mutation, KRAS gene mutation, and various other microsatellite instability and all can also lead to carcinoma. So those with a family history of colorectal cancer have increased risk of colorectal cancer, or those who have got polyp or adenoma themselves have got increased risk of colorectal carcinoma as well. Here I would like to mention a condition, familial adenomatous polyposis coli. As I said, it is because of mutation in APC gene located on chromosome 5. In this condition, in early age, very early, by the time they reach puberty, they develop multiple polyps, hundreds of polyps in the colon. And by the time they are 40, 100% of them get colorectal carcinoma, familial adenomatous polyposis coli. And in this condition, of course, radical treatment is needed, which is total proctocolectomy, because whole colon is involved. So a total proctocolectomy with ileoanal anastomosis is done. or you can do total proctocolectomy with permanent end ileostomy in these cases. Okay, so FAP is responsible for about 1% of colorectal carcinoma. Now, another genetic factor is condition is HNPCC, hereditary non-polyposis colorectal carcinoma. Here also some genetic mutations changes occur, and these patients they develop carcinoma not only in colon but in various other organs also, like stomach, pancreas, and in females ovary, endometrium carcinoma occurs. Colonic carcinoma is more on the right side in these cases. They occur in those less than 50 years of age. Okay. So this is one condition where colorectal carcinoma, there is increased incidence of colorectal carcinoma. Various polyps are there. You know, polyps, the abnormal growth, they are in the colon. The types of polyps are, as you know, adenomatous polyp. Okay, adenomatous polyps are of three types: histologically tubular, tubulovillous, and villous. Tubular adenoma, they form tubular structure when you examine microscope. Tubulovillous has both tubular and villous element. Villous, they look like frond of a snake, large. They are usually sessile and they are prone to malignancy. See, in polyp, size is important. If they are big size, like more than 1 centimeter or about 2 centimeter, big polyp is there, then there is about 40% chance of being malignant. Especially villous polyp, they are more prone to malignancy. Villous polyp causes mucus and diarrhea, leading to potassium loss, hypokalemia, and fluid electrolyte disturbance. Other polyp, you know, inflammatory polyp as seen in ulcerative colitis, Crohn's disease. By the way, ulcerative colitis is also a risk factor for rectal carcinoma, colorectal carcinoma. Longer ulcerative colitis a patient has, more the chance that he will have colonic or rectal carcinoma. Okay. In inflammatory bowel disease, ulcerative and Crohn's, you get a polyp which we call inflammatory polyp or pseudopolyps. Okay, pseudopolyps. Then the polyps are hematomatous polyp. They are hematoma like in juvenile polyp in young adult, in young children. Polyps occur which are usually solitary and they present with bleeding product. So you have got adenomatous polyp, you have got hematomatous polyp, then you have inflammatory or pseudopolyps. Okay. There are also hyperplastic polyps, which are normal, small sessile polyps are there in normal people. They are usually benign, and they rarely undergo malignant change. Okay. So, but these polyps, especially the adenomatous polyp, they are very important because they can lead to malignancy. That's what we call adenoma carcinoma sequence. Most of these colorectal carcinoma can start as an adenoma, which subsequently has dysplastic change and become malignant into carcinoma rectum. Okay, so to summarize, we have sporadic 80%, then we have high risk as in elderly people, obesity, tobacco, smoking, and then we have genetic predisposition as in FAP, HNPCC, other mutations as in P53, KRAS genes, and chronic inflammatory bowel disease, long-standing, especially for more than 10 years, we have got increased risk of rectal carcinoma. Okay, so this is about histologically, as I said, it is adenocarcinoma. It can be well differentiated. You know, well differentiated means it resembles its parent cells in differentiation, in size and shape. So well differentiated has got better prognosis. The less they resemble their parent cell, we call it undifferentiated, and that carries a poor prognosis. Moreover, some of these rectal carcinoma can have mainly mucus in them, mucoid, and this mucus accumulates in the cell and that pushes the nucleus to the periphery, which looks like in microscope as looks like ring, signet ring carcinoma. We call it signet ring carcinoma, which has got poor prognosis as well. Okay. So this is about, so how does this carcinoma spread? Basically, as you know, any carcinoma, it spreads by local spread it can spread. So carcinoma of rectum, usually it's in mucosal growth, it starts in the mucosa, then it will involve spread circumferentially as well as longitudinally and also radially. Okay, so very advanced carcinoma will obliterate the lumen completely as it occurs in 1.5 to 2 years and can lead to intestinal obstruction. Okay, this carcinoma can go beyond the rectal wall and then involve, as in male there is, what structure is there in front of rectum is the bladder, urinary bladder and prostate. So it can involve prostate, urinary bladder. Laterally in both the sexes, the ureter is there, it can involve ureter and lead to hydroureter. In females anteriorly, uterus and vagina is there, so it can involve that and lead to fistula, rectovaginal fistula and all. Posteriorly, if it goes, there is sacrum behind the rectum, so it will involve the sacral fascia and later on sacral plexus of nerve, which can lead to severe back pain, isn't it? So this is how it spreads locally. Now another mode of spread is lymphatic spread. Carcinoma of rectum spreads through lymphatic, earlier stage and later by hematogenous. So where will the lymphatic go? As I told you previously, they all go to the inferior mesenteric nodes and from there to para-aortic nodes. So nodes will accompany the blood vessels and travel there in the inferior mesenteric. Some from the lower part can also go to internal iliac nodes. So these are the nodes will involve. Another mode of spread is hematogenous. By venous system it will spread as I told you in anatomy. Majority of the veins, they drain by inferior mesenteric vein into splenic and then into portal vein. So portal veins, by that system it will go to the liver and form multiple beds in the liver. Okay, by systemic it can go to lung, bone and adrenal and elsewhere. Okay, so and some spread can occur in the peritoneal cavity itself, intraperitoneal spread. So you have local spread, you have lymphatic spread, hematogenous spread involving liver, lung, adrenal, bone, etc. And you have spread in the peritoneum, carcinoma peritonei, where tumor emboli can implant on the peritoneal surfaces and lead to ascites and all. Okay, this is how it spreads. So, what are the symptoms? How will patient present to you if he has got carcinoma rectum? See, the symptoms usually are very vague. In early cases, won't be much symptom, and later on, bleeding. Bleeding is the commonest symptom of carcinoma rectum, and this bleeding is bright red in color. It's usually painless bleeding, painless, profuse, bright red in color. It can be separate from stool, it can be mixed with stool. So you see, it's very difficult to differentiate it from hemorrhoidal bleeding. So that's why history is important. You have to take a detailed history of this patient. It can mimic hemorrhoidal bleeding. Okay. Another common symptom is alteration in bowel habit. What is alteration in bowel habit? These patients with carcinoma rectum usually feel that they have to get up early in the morning for passing stool. Okay, but when they go, they usually pass little amount of stool with mucus. So this is called early morning diarrhea, and this mucus and blood is called spurious diarrhea or bloody slime as well. Okay, so patient has urge to go to the toilet again and again, resulting in little defecation. This is also called tenesmus. Okay, tenesmus. Later on, when the carcinoma involves the whole circumference, patient will become obstructed, patient will have constipation and all. Okay, so change in bowel habit is very important. The urge to get up early in the morning to defecate, and the urge to go again and again to the toilet, passing little amount of stool mixed with mucus and blood is a very characteristic feature of carcinoma of rectum. Okay, so change in bowel habit, bleeding per rectum. Then you can have symptoms when it involves behind sacral plexus and all. Bony pain, severe pain can occur. Patient can present with intestinal obstruction. When METS has occurred, patient can present with hard nodular liver, ascites and all. Okay, so when you do a general examination of these patients, you will find pallor. Abdominal examination, you can find hard nodular liver, ascites present, isn't it? So these are the presentation of patient with carcinoma of rectum. Then how do we investigate these patients? So when the occasion of carcinoma rectum comes, it's very important to take a proper history, complete history. Ask the patient for any bleeding per rectum, change in bowel habit, frequent urge to defecate again and again, bony pain and all, weight loss, lack of appetite, these all can occur. Okay, so important to take a proper history and then do a general examination, special emphasis on pallor, lymphadenopathy, hepatomegaly, ascites and all. And then you have to do a DRE examination. Turn the patient in the left lateral Sims position, do a DRE. You can feel within a finger's reach up to 8 to 10 centimeter. There can be an ulcerated lesion or a polypoidal lesion you can feel in the rectum. Okay, and so that suggests that there could be carcinoma rectum. Then you can do a sigmoidoscopy in these cases. Digit sigmoidoscopy. You can measure the distance from anal verge to the tumor, which is very important. And you can, and also if you are in patients with carcinoma rectum, full colonoscopy should be done. Why full colonoscopy? To see if there is second primary or a synchronous lesion elsewhere in the colon, or if it is associated with polyp, if there are other polyps somewhere in the colon or not. So and moreover you can take biopsy by sigmoidoscopy and colonoscopy. You can take biopsy from the lesion also. Okay, so this is what you have to do to investigate a patient. And of course in any carcinoma we do test for staging of the carcinoma. And here what we will do a CT chest, CT abdomen, CT pelvis, okay, to look for mets and spread. Can do in carcinoma rectum. MRI of pelvis is also very useful, which will tell you about the spread of carcinoma locally. And endorectal ultrasound and here a special colonoscope is there where ultrasound is integrated in that, and these help to delineate the various layers of the colonic wall or rectal wall, like mucosa, submucosa. Then you have muscular layer, muscularis propria and serosa. You can see that up to which level the tumor has gone and whether there is lymph node in the surrounding which are involved or not. These things are better delineated by MRI and endorectal ultrasound. And for other spread, CT chest, abdomen, pelvis is important. Blood investigation we do CEA level, carcinoembryonic antigen. It's very important to do it. Carcinoembryonic antigen, a very high level, more than 100, suggests that there is meds. On very high level also associated with poor prognosis. We do CEA level also to see that after operation, CEA level should come to baseline, normal. Then if it rises again, it means there a recurrence of disease has occurred. Okay, so CEA, high CEA level, poor prognosis, and CEA level which has returned to baseline and then rises again suggests recurrence of the disease. And of course you do all the normal tests like CBC, LFT, RFT and coagulation profile and all, and check for fitness for surgery and anesthesia. Okay. So this is how you investigate these patients. In the next lecture I will tell you about staging of the disease and the treatment of rectal carcinoma. Okay, thank you.